Evaluation of the foot and ankle, beginning with history. First, if I was there, my observations are going to make this a little bit easier to make a prognosis of. If anyone else was present, I'd get their observations. I want to find out how it happened, the mechanism of injury. Is it inversion, eversion, overuse? Did you step in a hole, step on somebody else's foot? Was there contact, torsion? We're going to find out if it's acute or chronic, when it happened, if there was previous injury, any sensations or sounds that she heard or felt when this happened, the pain, where it's located, the type, intensity, and movements that increase or decrease the pain, and her chief complaint. Also with history of the foot and ankle, or check to see if she has orthotics, or was she supposed to be wearing orthotics, brace, taped, or anything like that. Moving into inspection, we would bilaterally compare, looking for swelling, discoloration, deformities, wounds, scars, how she removed her shoe and sock. We're going to look at her shoe. Where did your shoe go? There. Going to inspect her shoe for a broken medial counter, indicating flat feet, excessive wear on the lateral border, indicating that she walks toeing in, scuffed toes, drop foot, absence of creases that she doesn't toe off, or oblique creases that she has hallux rigidus. Looking for any toe or foot abnormalities, such as Morton's toe, calluses, bunions, blisters, plantar's warts. She doesn't have any overlapping toes or claw toes. She doesn't appear to have any of those abnormalities. With the swelling, we're going to look to see if it's local or general. Local, secondary to a sprain, just one certain area, versus general, indicating trauma all over the foot and ankle. In the normal resting position, looking to see that the medial malleolus is more anterior and the lateral malleolus is more distal. Inspecting her arches bilaterally, the medial, the lateral, and the transverse arch. And then we could move into palpation. With palpation, I'm going to bilaterally compare for point tenderness. Also, if there is any swelling, the temperature, the moisture, the crepitus. Starting with the first metatarsal phalangeal joint, first metatarsal ray, first metatarsal cuneiform joint, first cuneiform, navicular tubercle, navicular bone, medial malleolus, calcaneus, medial tubercle of the calcaneus, lateral malleolus, peroneal tubercle, the fifth metatarsal phalangeal joint, fifth metatarsal ray, fifth styloid process, cuboid. I have the second, third, and fourth metatarsals, second and third cuneiforms. And on the plantar aspect, we have the heads of the metatarsals, and on the first metatarsal, we have the two sesamoid bones. Phalanges, I'm not sure if it's okay. With soft tissue, you have the start with the tibialis anterior. Okay, tibialis anterior muscle, tibialis posterior, peroneus longus and brevis, extensor, push against me, extensor hallucis longus, push against me with your toes, four tendons of the extensor digitorum longus, the one muscle. We have the deltoid ligament on the medial side. Laterally, we have the anterior talofibular ligament, calcaneofibular ligament, posterior talofibular ligament, the gastroc and the soleus muscle coming into the Achilles. We have the calcaneal bursa and retrocalcaneal bursa that I could feel only if it was inflamed. Plantar aspect, we have the plantar fascia that caused her any pain. She doesn't have plantar warts, no Morton's toes, no Morton's neuroma. The flexors. Flexor hallucis longus tendon, flexor digitorum longus, and the extensor digitorum brevis. Taylor's bunions. Retinaculum. Okay, and the peroneal retinaculum. Should be good. Okay, moving into testing. Range of motion, bilateral comparing, we could do this active, passive, or resistive. Show you, I'm going to do it actively, or passively, sorry. Dorsiflexion, plantar flexion, inversion, eversion, adduction, abduction, supination, pronation, metatarsal phalangeal flexion and IP flexion, metatarsal phalangeal extension and IP extension. Spread your toes for me. Metatarsal phalangeal abduction and adduction. Bring them back together. Special stability tests. First test, bump lever compression. Compress the tibia and fibula. Compress the metatarsals. Bump the calcaneus. Bump the toes. Then lever the tibia and fibula. All of that is testing for a fracture. Positive sign would be pain in any movement there. Anterior talofibular ligament test. This is testing for the ATFL ligament. For a sprain, pain would be increased pain as I push on it would be a positive sign. The Taylor rock tilt. Invert, evert. Got some clunking there. If they had laxity, instability, she's got bad ankles anyway, a lot of movement, but bilaterally it's equal, so there's no sprain. Testing the medial and the lateral ligaments, looking for pain and instability as a positive sign. Anterior drawer sign. Testing the anterior tibiofibular ligament, which I forgot to palpate, and the posterior tibiofibular ligament that you can't palpate. Again, pain and instability would be a positive sign. Tibial torsion, finding the tibial tuberosity, straight line, looking for that 15 degrees, which is there, so that's good. Positive sign would be anything other than the 15 degrees, indicating a deltoid ligament problem. Okay, so the next thing we're going to look at her arches. She does have an arch present, so she does not have a structural problem. I'm going to ask you to step down. And the arch only disappears slightly, so she does not have a functional problem as well. So it was a supple versus rigid test. She does not have a positive sign there. In this position, if she was having problems with the calf, I'd go the gastroc versus soleus muscle. Go ahead and stand up, go on your toes. Okay, and relax. If that caused pain, the problem would be either in the gastroc or the soleus. To distinguish between the two, I'd have her bend her knees and stay with the knees bent and go up on the toes again. Okay, relax. If that caused pain in the bent knee position, the soleus muscle was affected. If there was no pain, it was the gastroc muscle. Have you lay on your stomach. The next test is Homan sign. We do forceful dorsiflexion. Palpate the belly of the muscle. If that increases in pain, it's positive for deep thrombophlebitis, which is blood clot. And the last test is Thompson's test. Just relax. Testing for an Achilles tendon rupture. If when I did this she did not plantar flex passively, it would indicate a complete or partial rupture of the Achilles tendon. Okay, you can turn over. I would then make a prognosis of what I thought was wrong, refer her to a physician for a diagnosis and get any labs or x-rays done that we needed, and then hopefully that physician will refer her back to me for treatment. Time. I got time?
9:57.